And we're live. Hey, everybody. I'm so excited. Now, you knew I would be excited because, again, I've been making fun of Evan on the last couple of webinars and picking at him. It is meant with love because he's like family and I miss him terribly, which is why I made him get on early so we can do that. But if you are not familiar with the Dr. Evan Gwilliam with 5 million letters behind his name, in a nutshell, he's the clinical director for PayDC chiropractic software, graduated from Palmer College as valedictorian. No surprise there. He's a certified professional coder, an ICD-10 instructor, medical compliance specialist, certified professional, medical auditor, and all kinds of other stuff because, like, he knows everything. You see, is that even all the letters behind your name? Because I feel like we're a little short on this PowerPoint.
You know what? I actually changed them around a little bit, and I let a few of them kind of go by the wayside. I added CPCO a few weeks ago, which is what you have, right?
Yes. Certified Professional Compliance Officer. Yes. That Brandy Brimhall.
Mm-hmm.
Yeah, I was going to say Brandy helped me study for that test.
Yep, I had to shuffle some certifications around, but anyway, I just wanted to be like you guys.
Yes. When I first met Evan a long time ago, before he was known as my brother from another mother, I remember joking with him about all the letters on his business card, and he said he wasn't going to stop until they wrapped all the way around. Well, we'll say that I still have not received that business card with the letters wrapped all the way around, and I am still waiting. You're not that ambitious anymore?
Well, now I prioritize. I'm like, those 3 aren't that important. To put the most important ones at the anyway. I don't know.
All right, those are pretty impressive. The ones you have, though.
And actually, there's one that I earned several years ago that's very relevant to today's presentation. It's the last one there, CMHP, and it hasn't mattered really because this MIPS thing shifted and changed until now. And so now I get to say, hey, I went and did this. I was like a 8 or 10-hour course and then took a test. CMHP stands for Certified MIPS Healthcare Professional. I don't know anybody else who has it. Anyway, we'll get into it.
I don't know anybody else who has it either, but I'm going to just let you do your thing and tell everybody where did their G codes go.
All right. So listen, everybody, I am pleased to have you here with me. I was invited to provide this presentation, and when I've been asked to present it in the past, I've always been a little resistant because it's not that relevant to that huge a segment of the profession, which you'll see as we get into this. But everybody's been asking about this G code and like, wait a minute, I've been reporting this thing for years and then it says it's an invalid code or it's not existent or what. Oops, sorry, just dropped my water. What do we do? That's the question. What do we do? So this presentation is all about what happened to the G code and what's going on with MIPS, right? So we've already kind of talked a little bit about me, but I'm a chiropractor. I help run this PayDC EHR software. And if you're interested in looking at software, please, contact me and I'd love to share it with you. But I also have all these different certifications. And the one at the bottom there is, in fact, a course I completed, an exam that I passed on MIPS specifically. And it was back in 2016 or 17 when we thought it was going to be a bigger deal. And so I'm just so pleased that I can kind of keep that one on here and say, yeah, that's relevant to what's going on now. So let's just get into this. And in about 5 minutes, I'm going to answer the question, what happened to your G code? Okay, but most of this is really about MIPS. What is this program? What does it mean? Do I need to worry about it? How can I be aware? What do I need to change? I mean, I want you to understand the big picture, but I will answer the question, what happened to your G code? Okay, and if you don't know what I'm talking about, you will shortly. So let's go through a little history here, and then we're gonna build from there. And I did provide a number of handouts that are some reference material you can get yourself from CMS, qpp.cms.gov. I'm going to talk about that website a bunch too, qpp.cms.gov. It's where most of this information came from. I got some of the more relevant things and provided them so that they should be available to you. So here's the deal. In 2015, a law was passed called MACRA. It's the Medicare Access and Chip Reauthorization Act. Okay, and it created a program called the Quality Payment Program, and it fixed some problems with something called the Sustainable Growth Rate Formula. And there was an issue with how Medicare reimbursed and how it had to change every year to fit the budget, and there were problems. So they fixed that, and then they created the Quality Payment Program, or QPP. And what it did was it replaced several other programs, one of which was PQRS, which some of you may remember. PQRS actually got its start as something called PQRI back in 2006, so 15 years ago now. And there was a program called Meaningful Use that was a big deal back in 2011 is when that one started. And that was about EHR software. And then there was a program called the Value-Based Modifier, or VBM, that came out in 2015. It never really got off the ground because the Quality Payment Program kicked in 2017. And it replaced all three of these old programs, okay? And the purpose of it was really, they wanted clinicians to focus on caring for their patients instead of filling out paperwork. They wanted to reduce the clinician's burden of doing the administrative stuff. And they wanted Medicare patients to get better health outcomes. And so that was the driving force behind this. And so that's the purpose of this program, all right? Get better results, make doctors happier. I mean, sounds like good stuff. I mean, in principle, that sounds terrific, okay? Now, the Quality Payment Program has two pathways, and that's what you see here at the bottom of the slide. One is called MIPS, and the other one's called APMs. And so we're not going to talk much about APMs, but let me just give you the very brief overview. APMs have these different payment pathways. It's based on giving you an incentive, not so much for providing more care or the volume of care, but it's value-based care. And so the incentive payments are based on showing you get high quality, cost-effective care. And it's based on each patient, not on the volume or intensity of the care that's delivered. And it's in order to be a part of these APMs, you have to be part of an accountable care organization or a patient-centered medical home or these special bundled payment models they've come up with. So odds are very good that if you're a chiropractor and you're watching this, you have never heard of this before, or you have and it doesn't apply to you, and that's fine. I'm just going to tell you that there is this whole other pathway, and it really is what they want it to go down to, which is where they don't pay you for the number of services, but they pay you for the quality of care you deliver and the outcomes you're able to achieve. And the better outcomes you get, the more bonus money you're eligible for, essentially. Instead of that, what we're looking at is MIPS, okay? It's the Merit-Based Incentive Payment System. And it has 4 parts, so we're going to talk about these 4 parts today. But the one you see on your screen at the far left is quality. That's the one that has to do with these G codes, okay? But there's 3 other parts that maybe you didn't know about, and maybe you did, but we're going to go through them briefly, make sure you understand what's going on there, and you understand those options. So those are the 2 pathways under the Quality Payment Program, MIPS and APMs. And again, to find out more about this, I strongly encourage you to go to qpp.cms.gov. I mean, that's where all the extra information is going to be. So let's just jump right in and talk about MIPS eligibility. Okay, this is a government program that you can report information on. The question is, are you eligible for it? Okay, so here's how they determine if you are. They look at your National Provider Identifier, MPI number. They look at the tax IDs that are associated with your MPI. So that could be an individual or part of a group or a corporation. They look at those. And then they take whoever's enrolled in PICOS, which is where you get enrolled with Medicare. They look through that and they make sure that you're a provider that's enrolled with Medicare. They look at your claims for 2 different time periods and they compare them to each other. And I'm skipping certain details here, but that's the gist of it, is they look at you and look at your volume with Medicare, essentially, okay, based upon a combination of your MPI and your tax ID and these 2 different date periods that they're looking at, looking at your claims that you submitted to Medicare. And what they want to figure out is, do you exceed the low volume threshold for those 2 time periods? Okay, that's how they determine if you're eligible. So the question is, what's the low volume threshold? Well, the low volume threshold is you have to participate in MIPS. They call it eligibility, but I would call it requirement, right? You're required. If in both of those 12-month segments in the MIPS determination period, you, 1, bill more than $90,000 for Part B covered professional services. So that is sending claims to Medicare for covered professional services. For chiropractors, that's 98940, 98941, 98942. That's it. So if you exceed $90,000 in what you charge to Medicare for, in those 2 12-month periods, that's one of the criteria you have to meet. The next one is you have to see at least 200 unique Part B Medicare patients. So if you only have 100 different individuals that come through your office, that's not enough. You have to see 200. And you have to provide at least 200 or more covered services, which actually that one I think is a little easier for chiropractors to meet. I think if you do the math there, that's only a few every week or something. So it's not that hard to reach that 3rd one. But if you hit all 3 of these, you have to hit all 3 to be eligible, okay? Now, this data is a little bit old, and I can't recall how old it is, but the average chiro bills Medicare about $10,000 a year, not $90,000. Nationwide, the average chiro gets $10,000 a year. So those of you who just finished your taxes, and you got a statement from Medicare that said how much they gave you this past year from Medicare. 10,000 is average. Some of you may be at 40,000, some of you may be at 2,000, whatever, around 10, and about 44 individual patients. Okay, that's the average for chiropractors nationwide. So maybe you see more than that, maybe less. It really kind of depends on your demographics and so on. So I believe that the vast majority of chiropractors are not eligible for this program. Most chiros watching this are not going to have over $90,000 or 200 patients or 200 services, all three. And I'm knocking over my water again. I'll just drink the rest and put it down. Okay, put that safely away. So when it comes to what happened to those G codes, I believe that most doctors who have been reporting them didn't know that they didn't need to. Okay, you didn't need to for several years now. You had to back under old programs, but when they consolidated and changed some of the rules, it's not required. Okay, and we'll get into that a little more. So to be MIPS eligible, you also need to be on the list of clinicians that they approve for MIPS, and one of those is chiropractors, so we're there. You have to have enrolled with Medicare before 2021. So I'm talking about to be eligible to participate this year. I'm not talking about last year anymore. And we're making this presentation in 2021. You also cannot be part of an APM, which is that other pathway. Okay. So, and you have to exceed all three of the low volume threshold criteria, all three of them. And then I see a question that came in. I'm just going to, sorry, Christy, but I'm going to watch these. He says, what if we bill the services, but Medicare doesn't pay for them? I don't know, to be honest. It's for Medicare covered services. If they deny them, I don't know if that affects the eligibility or not. But if you bill, but we're not talking about x-rays or exams or therapies. We're talking about covered services. So it's just if you get $90,000 in CMT codes alone, and we're only getting paid $25 to $30 per CMT code, it's going to take a lot of visits. I haven't done the math, but a lot of visits to get to $90,000. Okay. If you bill it and they deny it, I don't know. The verbiage there is, did you bill? So I'm going to assume that means that whether they deny or pay, it's what you billed for covered services. Okay. Now, if you don't meet this criteria, but you do meet one of the criteria, like, oh, I see more than 200 services. I do more than 200 services. I bill Medicare for about 300 or 400 services every year. Well, you could elect to opt into MIPS if you want. You only have to exceed one or two of the three low volume threshold criteria. So you're welcome to do that. And you might want to, because you might find that there's some financial incentive and other reasons to do so. Okay. So you can opt in, which means you're basically treated the same as someone who is eligible. Now, if you're not sure if you're eligible, here's what you do. Like the doctor just asked that question. You want to go, how do I know if I've satisfied this? Go to this qpp.cms.gov, go to participation lookup. I think that this is right on the home page there. And you type in your MPI number and it'll tell you if you're eligible. All right. And that's how you know. And if you're not eligible, but you want to opt in, you just need to figure out if you saw more than 200 services or 200 separate individuals or did more than $90,000. And you can go ahead and opt in if you want. And I believe you need to go and log in at qppcms.gov to tell them you want to opt in. Okay. So what happens if you do this, all right, if you are MIPS eligible or you elect to opt in, here's what happens. You'll be required to report that data to MIPS. Okay. You're going to receive performance feedback. They're going to tell you how you did. You're going to receive a payment adjustment. It's going to be a positive adjustment, a negative adjustment, or a neutral adjustment. And just so you understand, the way that the payment adjustment works, it's 2 years after the reporting period. So you report for 2021, and the payments that are going to go up or down, the adjustments are going to come 2023, all right, based on how you did in 2021. So if some of you have participated in previous years, what the bonus or penalty you're getting this year is based on what you did in 2019, because this is 2021. And the bonus for the 2023, or the payment adjustment, I should say, is going to be somewhere between -9% and +9% times a scaling factor. The thing about the incentive payments for this program is it had to be budget neutral. So the way it works is for all those participating in this whole pool, they see how many are getting penalized for doing poorly. And maybe that's $500,000 or $500 million, whatever. And that's how much money is available for the incentive for the positive payment adjustments or the bonuses. So if there's very few people who did poorly, there's less money available for those who did well, and vice versa. I mean, if there's lots. So it's kind of interesting how they structured it. So they say between 9% either direction, but it could go up or down depending on how much money is available. Also, and this is interesting, your information will be published on doctors and clinicians in the Medicare Care Compare website. It used to be called Physician Compare. On the Medicare Care Compare website, patients can go and look up a doctor and find out how they perform if they are considered high quality, low cost providers. Okay, you can go and look yourself up on there now. In fact, if we have time, I can pull up the page and show you guys what happens. But basically, there's not a lot of data in there on chiropractors in general because most of them aren't reporting on MIPS. So all it really says is, here's the doctor, here's when they graduated from school. It doesn't have data about how they did on certain quality measures or if they have good technology in their office. But other clinicians, you can go in there and look for a heart surgeon or whatever and see how they've done in the past on this program. So that's what this Compare website does. It forces you to realize that you can't slack off because the government's going to publish your performance and make it available to the public. And so that's kind of, they're trying to incentivize you to try to do better than your peers, you know? So you can also report voluntarily, which is what I believe a lot of you probably have been doing, is where you didn't meet any of those eligibility thresholds. You didn't choose to opt in, but you still reported those G codes for the last several years. If you voluntarily report for MIPS, you can do this. And here's what happens. You will receive performance feedback. So you can find out how you compare to your peers. So it'll help you get ready for when and if you do become eligible. If they lower that low volume threshold and everybody has to do it, it'll help you kind of know where you stand before then. And you can have your data published on that Medicare Care Compare website so that you can show that you did better with these certain quality measures and that you're a better doctor than everybody else who didn't report or reported and said they did a bad job. But if you choose to do so voluntarily, meaning you didn't meet the low volume threshold, you didn't opt in, you do not get a payment adjustment. Okay, you don't get any sort of bonus or a penalty. You're not eligible for that part of the program. And they set up certain benchmarks for certain measures, and you won't be included in the calculation for those, which we'll talk about a little bit later on here. Okay, so that's what voluntary reporting is. And what you're reporting on is the 4 categories of MIPS. So MIPS has these 4 categories, but try to think of it more like a single program that's focused on rewarding clinicians for improving quality and penalizing clinicians for having poor quality or not participating. Okay, the reason they put together this program was they figured, look, the ways we can change clinician behavior is we can pay them more. That motivates doctors, right? We can make them more satisfied so their job isn't as hard, so they don't have as much administrative tasks to do, but they're more happy with their jobs. And we can help them avoid public humiliation, which means keep them off that Compare website, or not keep them off of it, but make sure that they are pleased with the data they put there. So this MIPS program offers payment incentives. It consolidates other programs, so it's supposed to be simpler, although I'd argue it's still pretty complicated. And it gives clinicians the flexibility to choose how to participate in them so they can find things that make them look good and they aren't forced to go down a certain path that doesn't fit their practice, and improve your score so you look good on that public website. So the 4 categories are quality, which is showing you provide quality care and reporting on performance measures. That's where these G codes come in. Promoting interoperability, which shows that you are using the latest and greatest electronic information to tell the story, to make the data available in an easy-to-use format for other entities. Improvement activities, which is things like participating in registries to give data about public health information, coordinating care with other providers, stuff like that. And then cost. How much do you cost? Do you cost less than the next doctor to get the same patient better? You know, and if you cost less, then you're considered a better provider. So these are the 4 categories of MIPS. And what happens is you're supposed to report on each of these, and Medicare collects this data, and then they analyze it and they combine it and come out with a score. And the 2021 MIPS score is broken down as you see here. 40% is based on quality, and that's the stuff we're going to spend the most time talking about today. The quality measures you can report on. 25% is promoting interoperability, which is the EHR, the software technology side of it. 20% is cost, and that has slowly increased over the years. And then the smallest chunk here is 15% for the improvement activities, which is showing clinical improvement above and beyond. So last year, the quality portion was bigger. It was 45%, and cost was only 15%. And they traded off a little bit. They're supposed to balance out at 30% each. So the brown and the blue one here is supposed to be 30% each next year, but they may push that off. They've been doing that for a while. So this is what they do is they come up with this final score. They see how you do, and they look at you compared to your peers. And if you did well, you get the bonus. And if you did poorly, you get penalized. And if you're in the middle, you get neutral. Okay, and that's kind of the high-level version of this program, all right? So stay with me, because what I'd like to do now is go through each of those 4 categories with you, spending the most time on quality because it's the one that is the most applicable to what we're doing here. So MIPS quality is 40% of your final score. And basically what it is they want data on 6 quality measures on at least 70% of your patients who were seen between January 1st and December 31st of this year. And they've got all these measures like listed out in this database that you can search through at qpp.cms.gov. And there's different measures. For example, they have measures called outcome measures. And those outcome measures are the golden child of the measure types because they show a patient's health outcome after a certain clinical action was taken. Okay, these outcome measures reveal insights into patient-reported outcomes. It measures patient perception and satisfaction and clinical outcomes. Then they have measures they call high priority, which are other things like patient safety, efficacy, care coordination. And then there's other types too. And it gets really complicated. There's hundreds of these things. There's also, though, there's specialty measure sets. And up until last year, I think it was the year before actually, there was no specialty measure set for chiropractors. And now there is. So I'm going to show you what's in that specialty measure set so you can see some that they suggest for chiropractors. But before we go there, this is what the title of this presentation is about, is the measure that was called Measure 131, Pain Assessment and Follow-Up, is gone. They change these measures around from year to year based on what they need to know and what they think is most useful and helpful. So as of January 1st, 2021, Measure 131 was removed. And when you reported on Measure 131, you reported a code like G8730, which said that you administered a pain assessment and you made a plan around the patient's pain rating, okay? And so ever since that measure came out, I mean, I think it was 15 years ago, you were able to report this code and say, yeah, we assessed pain and it's part of our measures to see how the patient's doing. Well, they don't care about that measure anymore for some reason. And when that measure got deleted, these G codes went with it, along with a few other codes that were part of this measure. So the question then is, well, if that code is gone, what do I report? And the answer is you don't. There's no way to report on this information anymore because that measure is gone. And you probably weren't eligible in the first place. You didn't need to be reporting those G codes for the last several years. So just don't worry about it. It's not going to affect you one way or the other until they make it mandatory again, which they did way back when it was part of the older program. So that's the short answer is just don't worry about it. Don't report anything in addition. But if you really want to, I'm going to show you now what else you can do, okay, instead of that measure. So in the measures that they have on their website, they say there's 8 measures in the chiropractic medicine specialty measure set, okay? One of them is the one we've been using forever. The other one is Measure 182, Functional Outcome Assessment. That's the other one you've been reporting on for a long time. It's been around for quite a while. Still there. Nothing has really changed on that one, okay? But we're going to still review it here just to make sure you know what's going on. Then the other 7 measures are all kind of the same sort of thing. They're all functional status change for patients with, and then they have all these different types of things that the patients might have. A low back impairment, a neck impairment, a shoulder impairment, a hip impairment, etc. The ones I think are most relevant to chiropractors are going to be number 220 for the low back and number 478 for the neck. But you can see there's some others, okay? And you can go and get the details for the others if you want. But I sent Christy the actual measures for low back, neck, and then the number 182 for the functional outcome assessment, the old one. So those 3 are there for you to download if you want to review them. You can just go get them yourself, though, from qpp.cms.gov. Now, this gets a little more complicated because there are different kinds of measures. They have 6, they call them collection types. And Measure 182, Functional Outcome Assessment, we've been doing for a long time, is considered a Medicare Part B claims measure, meaning you can report it right there on a claim. These other ones, though, these functional status ones, these other 7, are considered MIPS clinical quality measures. And I'll be honest with you, I'm not entirely sure what the difference is. I don't quite follow it, and I'll talk to you about it a little later. I'll show you the verbiage, and you can decide for yourself, okay, kind of what we're trying to figure out with these other guys. So what I'd like to do is take you through Measure 182, and then I'm going to show you 220 and 478 as well, because those are ones that chiropractors can report on, and they're pretty good ones. Here's a hitch, though. We are told that you should report on at least 6 measures. And I believe that you can go and talk to someone there and say, listen, I didn't have any patients with these other problems, so I was only able to report on these few measures because those are the kinds of things I see in my office. And they will give you exceptions and let you adjust your score if you're really concerned about it. So there's quite a few things in this program for years and years that we're like, well, how does that fit for chiros? And we never really got straight answers. And I went straight to the source and I asked. And they're getting better now that they created their own measure set. But again, I don't know that a lot of chiros would have occasion to report on 6 of these 8 measures. You know, I don't know if, and besides, when you're reporting on knee impairment, you know, you only get paid to treat the spine by Medicare. So it's a big mess. But anyway, these are the ones they gave us. And the way that these ones became eligible for chiropractors is you could report a 98940 or 2. If you do, then you can use one of these measures. Okay. That's kind of how they got into these, the 8 measures. They all say they have what's called the denominator, and a denominator is the eligibility for that measure. And the denominators, which I'll talk about a little bit more, includes 98940 1 or 2. All right. So I hope you guys are still with me. Let's keep going here. I just kind of, scrolled through these measures. Here's some other ones that you might want to consider. And if you feel that, hey, gosh, in my office, we always do body mass index. That's pretty standard in our office. Or we always just ask the patient if they did influenza, if they got their influenza immunization this year. You can look up these measures if you would like and see if they apply to the way that you practice and report on them instead. They're not part of the chiropractic data set. I believe you can report on these as long as you report an E&M code. However, the rules aren't really clear on what if you report E&M code and Medicare doesn't recognize it because you're a chiropractor, and can you then report? They aren't very clear. The rules don't get to that level, and I wasn't able to determine that for certain, but I believe you can. You report an E&M code to Medicare. You put the 2.5 and the GY modifiers on there to tell Medicare it's going to be denied. And then you can also report on one of these measures if you feel like they apply to your clinic and you want to report quality measures to get a good score and show that you're a good quality provider and maybe be eligible for a payment incentive. All right. So let's take a look at measure 182. This is our old standard. This one's been around forever. For those of you who have been reporting, you may recognize this one. It's functional outcome assessment. And I apologize, but I am going to read this to you real quick, just because I want to get the base here. It says, percentage of visits for patients aged 18 years and older with documentation of a current functional outcome assessment using a standardized functional outcome assessment tool on the date of the encounter, and documentation of a care plan based on identified functional outcome deficiencies on the date of the identified deficiencies. Whew. That's a word. That was a mouthful. A couple things. When you look up this rule, and by the way, you have a copy of this one in the handouts, okay? So you can look at the official stuff. It says this is supposed to be reported on every visit where it's denominator eligible, which means every visit where you report a 98940 or 1 or 2. So you report this on every single encounter, and you report it through claims, and it's eligible for visits where you are reporting 98940 1 or 2 or an E&M code. And examples of standardized tools include the Oswestry Disability Index, the Rowland-Morris Questionnaire, the Neck Disability Index, and so on. Standardized tools, though, are not limited to the ones you see here. It's anything that's considered normalized and validated, meaning it's been in a peer-reviewed journal and checked to make sure it's useful. Okay, so if you have other tools you like, for example, it's escaping me now, but other tools, you can use them as long as you can prove they were normalized and validated, okay? My advice to you, though, is that you actually name the tool somewhere in the documentation and explain what it is and maybe even where it came from. Now, the visual analog scale is not considered a standardized outcome assessment tool because it doesn't measure, it's not multidimensional, and it doesn't measure NMS capacity in addition to pain. So visual analog is not sufficient for this one. That's what you did for the old measure that got deleted, 131. Okay, so a couple of definitions. Now you'll notice here I bolded a few of the words here in this measure. Current care plan and deficiencies. Well, in the guidelines, they say current is defined as something that's been done within the last 30 days. So if you've given them an outcome assessment questionnaire in the last 30 days, it's current. If it's day 31, not current. Okay, and they define a care plan as, I don't think there's any surprises here, but I have that here whole paragraph. It's just basically the planned activities that are based on the deficiencies that are going to try to get the patient better. We have goals and a schedule and all this stuff. And then a deficiency is an impairment or loss of function, and it can include things like back pain, neck pain, pain in the joints, legs. This is, restricted range of motion. This is all stuff chiropractors see all the time. So that part, I think that this measure fits really nicely for chiropractors, something we see. It lines up very well with the work that we do. Okay. So those are just a few definitions that I pulled out of the 12-page official explanation of what this measure is. So the question is, what do? Let's say you've done all that. You've given an outcome assessment, and the patient got a score that was significant, and you put together a care plan that said, ooh, we're going to improve this score. We're going to assess this patient's function, and we're going to get them from 50 to 25. If that's what you do, and you gave that tool that day, then you report G8539. This has been around for a long time. Those of you who've been reporting probably recognize this one as one you report at the first visit. G8539 says, I gave someone an outcome assessment tool. It was positive, meaning they didn't say zero. They have some outcome, they have some functional deficiencies. And I created a care plan, and I put the care plan, I built it around this tool. If you did that, report G8539. And if you gave that tool in the last 30 days, then you would report G8942, and you don't have to fill out the tool over and over again. You fill it out, you do G8539, and then in the next 30 days, as you see the patient again, you report G8942. If you give them the tool and their score is 0 and they have no problems anymore, you release them from care, then you report G8542. All three of these are considered that you've met the performance, and you would get a positive score for reporting one of these three codes. And another way to look at it is you report G8539 at the first visit when you give the tool out and you set up your care plan. And when you do a re-exam, if you re-administer the tool, and G8942 would be every other visit, and G8542 would be the discharge visit, perhaps. So as an example, let's say that Susie Durkin scored a 42 on the Neck Disability Index at the evaluation last week. The goal is to improve by 50% by May 21st. So I've administered a tool that was positive, and I put together a plan. In this case, I report G8942, which is in the last 30 days, I administered a tool, and we're still working on it. And that's how you report on Measure 182. There are a couple of other codes you could report with this, but I don't think you should. If you reported G8540, you'd be saying, I didn't give the patient an outcome assessment, a functional outcome assessment, because they weren't eligible. Maybe they were incapacitated or mentally incapable. G9227 is, I gave them an outcome assessment, but they're not eligible for a care plan for some reason. And if you do those, it doesn't count for you or against you in terms of scoring. That's why they're called exceptions. But if you report the other two codes you see here, you didn't meet the performance. You said, I had a patient who was eligible, but I did not give them an outcome assessment tool. I'm not going to tell you why. It's a secret. Or I gave them an outcome assessment tool, but I didn't put it into the care plan because I'm lazy and I don't want you to know that. But I'll report it to you anyway. So I'll report G8543. And if you do that, it's going to count against you and make you look bad. So I don't know why anyone would ever report these. I'd rather not report at all than report that I'm doing a crappy job. But that's what these codes are for. Okay. And they're just all outlined in the measure. So that's Measure 182. That's the one that's been around forever. It hasn't changed. And you report it at every claim during, whenever you report a denominator eligible code, which is 98940 or 1 or 2. Okay. That's the first measure. I hope everybody's with me so far, because now I'm going to get into the new ones that you may have never seen before. All right. This is Measure 478. It's functional status change for patients with neck impairments. Now, remember, there were 7 other measures we could look at, and they're all different body regions. And I just think the neck and the back are the ones worth talking about in a webinar. So I'm going to explain to you how to do Measure 478. For those of you who are like, hey, I was reporting that G8730 on that pain assessment measure for so long. I want to report something else. I really want to. Can I please? Sure. Here's one that you should consider. Okay. This is one you could do instead. Here's what this one is. A patient comes in with a neck impairment. Okay. And that can be a variety of things. It's pretty broad and it fits most chiropractic scenarios. Then you go in and you have the patient fill out something called it's the PROPM, whatever. It's this online tool that contracted with Medicare for neck impairments. And it's a adaptive test. The computer responds to different things. It asks about your age and gender and other factors. And then it asks about your complaints, and it comes up with a score based upon where that patient is relative to everybody else. Okay. So it's a lot like other outcome assessment tools, but it's a little more sophisticated because it compares you to others. Okay. And now there's a paper version of this tool, but the paper version doesn't allow that comparison. So I'm not actually clear on how you could do the paper version. So that's what this is. You do have to fill out this tool. So here's what it looks like. Oh, no, I'll show you what it looks like in just a second. First, here's what you need to do. once per treatment episode, not per visit, but per treatment episode. So if you saw them for 10 visits or 5 visits or whatever, it's for once during that episode of care, you submit that score at the beginning and the end of the treatment episode. And the denominator for this one is if you report an E&M code or one of the chiropractic manipulation codes or a code that's M1143, you may have never seen before. M1143 says start of an episode of care. And you have to report at the end of care M1009, which is end of an episode of care. Okay, that's new, but you have to report that at the end of that episode. You don't have to report, from what I understand, you don't have to report the M1143 at the beginning of an episode, but you can. But you do have to report the M1009 at the end. Okay, so you're saying, here's the episode from visit 1 to visit 10. Okay. And if you did all that, then you could report one of these 3 codes. G2152 is your residual score is equal to or greater than 0. G2166 is patient wasn't able to complete the questionnaire, and G2167 is the score is less than 0. Okay, so here's what this means. I need to show you the questionnaire before I can explain the scoring. So this is a paper version of it, the tool, and I kind of just did a screenshot and threw it up here. Again, it's got 10 items on it, and it's kind of nice. You can get a score, but again, it doesn't provide that comparison, which I think is required for this measure. If you do it electronically and you go through the questions, it takes just a couple minutes. I went and did it myself, and you guys can do it. You can. I didn't put the link up on here, but the link is in the files that were sent to you, and you can go and search for this until you find it. You could do a Google search for whatever the proper phrase was, PROM, neck status, functional status change. In this example, I put in mostly my information. I made up an injury, and I put my age and so on, and it said the functional score for filling out this tool was 54. So the projected improvement is 19. So this tool, what they're having you do is say, look, we think you should improve by 19 points. And if you do, you'd report, if you improve by 19 or more points, then you'd report G2152, which is the residual score is greater than or equal to 0. If you did worse than 19, the patient didn't get as much better as the computer thought they should, then you'd report G1267, and that would mean that you didn't do a very good job. Your patient didn't get as good as the computer thought they should. Okay, there wasn't much improvement. Hope that makes sense. Okay, so you come up with a score. You're projected to improve by 19. If you improve by 19 or better, then you report that code that says you did a great job and you got your patient better than what this tool expected. But if it's less than 19, then you have to report the code that says I was below. Now, you're not always going to get every patient better every time. There's going to be all these special circumstances. So they've told us they're going to calculate performance based on 3 different things. They're going to look at it at a patient level, and they'll understand that. But they're also going to look at it as a clinician. They'll go, well, we're going to look at all your different patients and see if all of them didn't do better, or if all of them, if there was some hit and miss, that's okay. And they'll also look at the entire clinic if you're part of a group, and they'll compare you to the rest of the clinic and see how it looks. So they're going to kind of average things in. The motivation behind this and the rationale, they explain, they want the clinician to ask 4 questions, okay, or to consider 4 things. They want the provider to figure out the patient's perception of how they're doing, of their level of function. They want the provider to consider if they should modify their care plan. They want the provider to decide whether or not they should discharge the patient sooner or later. And they want the provider to consider if they should send the patient over to a different provider. And they're hoping that doing this type of quality measure with this outcome assessment tool, the doctors will consider these questions and therefore deliver better care, okay? And the patients will have better outcomes. That's the rationale behind this thing. All right, so that's measure 478, neck impairments. Here's another new measure, 220, functional status change for patients with low back impairments. It's very similar, but there's just a few little things I want to show you. So the same thing, you go on to this photo patient outcomes, and again, you can Google this. I mean, if you really look tiny on your screen there, you can see the URL, but you can Google this and find it. It's free for you to use, or to have your patients go in there and put in their information, then you can get the results and put it in their file. And then report on these measures. So this is the low back version of that same thing. And just like the other one, they say once per treatment episode, not per encounter, but per treatment episode. So you treat them for this low back thing for 5 visits or 10 visits. And you come up with a score at the beginning, and it gives you a prediction of how much better the patient should become. And if you get them better than that, then you report favorably. And if you don't, you report negatively. So G8659 is we did better than the tool predicted, Now this one also lists specific diagnosis codes for the low back. There's actually hundreds of them, and you scan through them. It includes M990s and a bunch of other common diagnosis codes for chiropractors to use for the low back. You can, just like before, you can report the CMT codes or the E&M codes or M1121, which is the beginning of an episode of care. And then at the end, you need to report M1012 to show the end of the episode of care, okay? And then you would report the G8659 if you did better than the tool predicted, you would. And then there's a few other codes you could report. There's exceptions. If you report M1123, it's, well, I evaluated the patient for low back impairment and I determined they didn't need any care. They could stay home. They just got a consult and I sent them away. You can report that. And that's an exception, meaning it won't count this measure for you or against you. It just says, okay, you tried, but. Or M1124 is the patient left for surgery. They didn't, you sent them over because that's what you determined they needed. You're not going to get, it's not going to count against you if they had to go for surgery. Or M1125 is, well, they didn't follow this care plan or do the whole episode for personal reasons, maybe transportation or finances. Or G9732, the patient refused. They absolutely despise the tool and they refuse to fill it out or something. Okay. But you could also report that you got worse than 0, and that's G8660, meaning the tool said they'd improved by 20 points. I only got better by 10. Or you could report G8543, which is, well, I started, but I didn't really finish, and I'm not going to tell anybody why. I didn't document the reason, so that counts against you when you say you did a bad job. All right. So that is the two examples of these outcome deficiency measures. The question is, how do you report them? Well, it seems like you report them the same way as you would for the outcome assessment tool, where you just put a G code onto a claim, and that's that. I think that's what you're supposed to do, honestly, but they're not called claims measures. When you look up in the official guidelines how to report these two measures, this is what it says. So I put the official verbiage up here for you, and I'll be honest with you, I don't understand it. I wish I could tell you exactly how to report on these. I think you should just follow what we did there and put a G code in once during an episode of care, and that's that. But it says here, it says measure data may be submitted by individual MIPS eligible clinicians. And then it says quality data codes listed do not need to be submitted by MIPS eligible clinicians. And you can read this. I don't understand it. It talks about having third parties reported on claims, but can you report on claims or do you have to report it some other way? I'm not entirely clear. So I'm sorry about that. Try reporting on claims and see what happens. That's my advice. I looked everywhere and I could not get the solid answer to this one, how to report these measures, but that's their official explanation right here. So that's all we get. So let's say you report a bunch of these measures, whether whichever ones you want, they work for you, they don't. At the end, Medicare determines if you've achieved these measures by comparing you against a benchmark, and there needs to be a benchmark available, which is data they've collected in the past on others. There needs to be at least 20 cases. So if you only see 5 patients in a year for Medicare, you can't qualify for this. And it has to be at least 70% of your patient base. So there's some you can skip. You don't have to do on every patient, but at least 70% of them in order to be considered eligible to count towards your score for the quality category of MIPS. Now, the scoring also has other little bonuses. For example, if you have a certified electronic health record technology, an EHR system, and you can submit measures through it, you get a couple of bonus points for that. If you submit high quality measures through there. There's also 6 bonus points for small practices who submit just one measure. So you can get bonus points just for being small. And a small practice, for the purposes of this program, are defined as those with 15 or fewer clinicians, which is most chiropractors have 15 or fewer in their group. So 6 bonus points just for being little. You can also get up to 10 bonus points if you improve over the prior year. So if your overall score is down here and you do a little better the next year, you get 10 bonus points for that. And so they really want you to show that you're improving the quality of care in your office. Okay, that is the first and most important category of MIPS, quality. Okay, but I'm going to show you the other 3 categories in the time we have remaining. Just briefly, promoting interoperability is 25% of your final score. This is the use of technology and electronic health records in your office. Okay, the government determined years and years ago that paper records were inefficient and time-consuming, that electronic records would be better, and it would increase the quality of care and the ability to share information and so on. And so they encourage you to engage the patients and exchange information using an EHR system that they have a certification set out for, where they say, look, it has to meet these certain standards, and if it does, then you can do that. There are 38 measures that they came up with for reporting on promoting interoperability, and they're in 4 different groups. And this is reported for 90 continuous days. So the last one was on 365 days. This is just for 90 days or more, which means you have to start reporting this by October 2nd, because there's only 90 days left in the year at that point. And examples would be, does your EHR do e-prescribing? They believe that e-prescribing is more efficient than handwritten because of legibility and other things. And so if your EHR does e-prescribing and you use it, which chiropractors don't, then you would get credit for that measure for promoting interoperability. If you use registries to report public health data, if you're able to prove that you can share information with another electronic system, all those things you can report that you did those things during a 90-day period, and you get points for that, and you get a better score in this part of MIPS, okay? But there are exceptions that are hardships. If you say that you're in a small practice, which is less than 15 providers, then you don't have to do this part of MIPS. And again, that's most chiropractors I know, or less than 15 in the group. Or if you can say, I have a EHR, but it became decertified, they won't count that against you. If you say, I live in an area where I cannot get decent internet, there's no way for me to get a good internet connectivity, so I can't really send data and so on. Or I have other extreme or uncontrollable circumstances, like a pandemic. You could use the pandemic as an excuse why you couldn't do this part. Or you are part of a group and you can't access EHR. You have no choice. You're not the one who can acquire a certified EHR technology. So I believe that most chiros would qualify for one of these exceptions and don't need to report on promoting interoperability, but you probably still could if you wanted to. And if you found an EHR that was 2015 certified, you could potentially participate in this. It's just, this is geared more towards medical providers and patients with other kinds of conditions than what typically seen in a chiropractic office. Okay. The next chunk of the MIPS score is improvement activities. This is 15% of the final score, so the smallest category. And this is, it's measuring your participation activities that improve clinical practice. They want you to show that you're, clinically improving, I guess. And this needs to be reported for at least 90 continuous days during the performance period. So again, you have to start at the latest October 2nd, because then you have 90 days. And the way that they do this one is they've got high-weighted and medium-weighted activities. There's no low-weighted ones. And the high-weighted ones are worth 20 points, and the medium-weighted ones were 10. And you have to get a total of 40. So you can see the different combinations here. And you can just look through all these activities and pick which ones fit your practice and go, yeah, I do this, I do that. So you can pick those, report on them, and hopefully get all the points. And then you get 15% of your MIPS score from this category. So here's examples. There's 105 different measures in the improvement activities. And I just picked some that looked interesting to me that I thought maybe chiropractors might want to report on. Look at that first one. Use of CDC guidelines for clinical decision support to prescribe opioids for chronic pain via clinical decision support. I don't know if chiropractors can report on that one, but it looked interesting. I know that the opioid thing is a big deal. So you could look into that one and see if it fits in your practice. Some of these others, engaging patients and families to guide improvement, collection of patient satisfaction data, implementation of improvements to timely communication of test results. Those are examples of improvement activities you could pick and report on. Remember, you have 2 high-weighted or 1 high-weighted and 2 medium or 4 mediums, and you do all that stuff. You try to get as many of the 40 points as you can based upon what you report. And you can go in and look up those measures. I'm not going to go through the details with you here. They're at qpp.cms.gov, and you can look them up. You want to report on these, you get that score. It counts towards a higher MIPS score. You do better than all your peers, you get a bonus. Okay, you do worse than all your peers, you get penalized. The fourth and final category of MIPS is cost. Okay, this represents 20% of your final score. What they're looking at here is, are you cheaper than everybody else? If the patient walks in to see you with a low back problem, can you get them better for $400 and everybody else takes $1,000? Because if so, then you're going to score really well in this category. What they do is they look at your claims data to calculate how much it costs to see you for a certain episode of care, and they compare you to the benchmark. They look at performance data for the performance period compared to others, and you have to do it for a minimum of 18 different episodes for Medicare patients, and there's 20 different measures they look at. The thing is, when you look at these measures, they're specific to conditions. So for a heart condition, here's the cost we're looking at. For someone with pneumonia who's been hospitalized, here's what we're looking at. And as far as I can tell, there's not really any cost one specific to the type of musculoskeletal stuff that's usually treated in a chiropractic office. But somehow or other, they're going to figure this out. Or if it's not eligible, then they'll cancel it out of the score and not count it against you, and just expand the rest of it to this. If you're not eligible for one of these, they've told us that they'll count the rest as if the other one wasn't even there. And so it doesn't count against you. Okay. So that's how this works. You take these 4 different categories, you report based on what you find that fits your practice and what's easiest for you. You go in and research what's available there, and you report what you're told to report, and you can get performance feedback, and then you can find out what your score is. And in 2 years, if you did well, you'll get a little bonus or a little penalty or no change. Okay, that's MIPS. So that may be overwhelming to some of you. And again, one of the takeaways is look, you're probably not eligible. Remember, go back and review the eligibility stuff. If you're not there, go to qpp.cms.gov, click on the eligibility, and type in your MPI number and find out if you need to report. And if you don't worry about this. However, I expect that sooner or later they'll either make this program mandatory, or in the past, there was comments by Blue Cross and I think it was Aetna, who both said, hey, we're going to do something like this too, because we like what Medicare is up to here about trying to provide higher quality care at a lower cost. We're going to do this, but we're going to wait for Medicare to flush it out. And Medicare is still flushing it out. This program is changing every year. They change the measures, they change the scoring. And so we're just going to have to wait and see. But understand this. This is the future of healthcare reimbursement. It's going to be something that you need to watch for. Someday, they're not going to pay us to do 10 adjustments. They're going to pay us to take a patient with a certain condition and get them better. And they're going to say, here's the chunk of money you can use to get them better. And if it takes 10 adjustments or 5 adjustments or therapies and no therapies, durable medical equipment, whatever, they're going to pay us the same amount based upon how good we are at getting them the outcome that they need. So that's what I predict is the future of healthcare reimbursement, value-based care instead of volume-based care. You don't get paid for doing more services. You get paid for providing value, which is solid outcomes, patients who are satisfied and get good results from care and at low cost. Okay. So here's what you need to do. Figure out if you need to or want to participate at all. Go to qpp.cms.gov and look around. Unfortunately, lots of stuff on there doesn't apply specifically to chiropractors, but look around and try to get a feel for it. It's where you can learn more about the measures and you can go and participate and see if you want to. Oh, I should throw out another thing for you. If you're below that threshold as an individual, you don't have to report, but you can also report as a group. And if you have 5 doctors in your group and it's one tax ID, right, as a corporation or something, the group can exceed the threshold. And that's not that hard. A single doctor, not going to do $90,000, but 5 doctors, yeah, you could hit $90,000. So I should let you know that you can also report as a group. And if you already do participate with Medicare as a group, you need to put in that NPI number to find out if that group is eligible, because then you need to be reporting all these things. You can also choose to report as part of a virtual group. You can join a group of other clinicians that you don't actually practice with, and you can get your performances tied together so that you all get the same score and be eligible for a bonus. You can go to qpp.cms.gov to find out how to become part of a virtual group. Okay, so consider that if you think it might be worthwhile. If you do a lot of Medicare and you want to be getting some bonus money in a couple of years, you might want to go and try to join a virtual group, because then you can get over the threshold and you don't have to actually be in business with these other people, but you can join them together. And you can find out more on the QPP website. So when they set up this, when they passed the law, the macro law, they set aside a bunch of money, $100 million, to set up groups that will provide help, okay? And I put the link here, but just go to qpp.cms.gov and go to the resources. You can find this. Basically, it takes you to a page that looks kind of like this. And all of these different contractors are being paid by the government to help small clinics and rural clinics get the help they need to figure out how to set up their QPP participation in MIPS. And so if you are currently in Texas, it looks like your contractor is called TMF, and there's a link to contact TMF and say, hey, I'm a chiropractor. Here's my Medicare stats. Help me out here. What do I report? How do I know which measure to do? Do I submit a claim? Do I need to log in and submit it through a portal? What's the deal? And so that's nice to have these resources here. That way you guys don't have to call me and ask me, because all I know I learned from the website. I've never actually done this myself. So if you want to go further than what I've shared with you today, go here and find one of these guys, one of these contractors, to hold your hand and walk you through how to participate successfully in MIPS. Okay. That is what happened to your G code. Okay, it was deleted and replaced with. I mean, it wasn't replaced, but there's all these other measures. There's all this other. There's a much bigger picture. That's what you need to know about MIPS as a chiropractor. So I'm hoping that was helpful to you. I don't know if there are going to be many questions because this particular topic is kind of overbearing. I'm going to go ahead and turn the time back over to Christy now and see if anyone wants to ask me any more. I'm going to throw out one more plug though. If you're looking at EHR software, there's my contact info. Shoot me an email and say, hey, I'd like to do a demo. I'll show you how to do how to use PDC. But what do you got? Questions about MIPS, Medicare, anything coming out? Anybody?
I've got one that says, what if we bill services that but Medicare does not pay for these? So obviously you did cover that, like what MIPS covers for chiropractic. But if you don't mind going over that again real quick.
Yeah, so again, my understanding is if you bill it and Medicare doesn't pay for it, then it counts, but it's only for covered services. So it has to be the adjustment codes. So if you bill for x-rays and they don't pay for them, as we know, it's statutorily excluded, that doesn't make a difference. That's not going to count towards that $90,000 threshold. But if you bill for an adjustment and it gets denied, I believe that still will count, but I don't know for certain. So that's my best guess.
And that was the only question that we had. Oh, well, no, we had a lot of questions just come in because I said that.
Okay.
Check on QPP website. It says the national provider identifier does not exist in the
PICOS.
Yeah, please try again later. I don't think we meet the threshold even as a group, so maybe that's why.
I don't think so. I think there's something else going on there. I believe that if you don't meet the threshold, it says not eligible. Like it tells you that. The fact that it says that you can't find you may be an issue, and either their site's got an issue or you need to call your Medicare contractor and ask them if there's something screwy with your MPI number. Because I should try it. I believe when you go in there and you're not eligible, it says not eligible. It doesn't say we can't find you. So that's definitely a concern.
It does say that. Because I was actually curious what would happen. So, I mean, we own practices until November, so I just put it in there to see what it would say, and it says not eligible. So I would definitely check that out, Heather, and see what's going on.
In fact, two assignments for you guys. Go there and check and see if you're eligible. And the other one is go to the Medicare Care Compare website and look yourself up just to see what it looks like on there. You'll find it interesting, and you can see what data is already available on you to the public. Medicare Care Compare.
If we do the MIPS, will we get dollars like the prior year program?
So if you either are eligible for MIPS or you opt in, as you remember we talked about, to opt in, you have to have one of the 3 low volume threshold criteria, 1 or 2 of them. Then you would be eligible to get incentive payment adjustments, but not for 2 more years, because the payment adjustments for 2023 are based on your performance in 2021. And if you want money today, it's based on what you did reported back in 2019. It's 2 years behind. And the scale of how much the bonus or the penalty could be changes every year. And I think 9% is what they said would be the max, which is where it's at now. So I don't know. That could change.
Okay. So a lot of people are asking about how to access the recording. And so it is, the recording will be available. If you are on here, you will get a link to the recording. So if you registered, you get it in about an hour or 2. I also just popped up the link. So if there's ever a webinar you want to look at, we keep all of them unless they are updated. So then we will delete it if it's no longer valid. But most of the stuff we do can stand the test of time. So you can find it on the archives page. Just click that link and you'll see those. Next week, we have Dr. James Raker, who's going to be talking about occupational medicine for chiropractors. He's going to be reviewing the 33 billion government mandated health services that companies, cities, counties, state, and federal agencies can pay to DCs to provide. So it should be an interesting topic. And this was by request. So we'll see what we learn next week with Dr. Raker. And then we're going to follow up the next week and talk with Fab about how to white label nutrition for your practice. And then we're going to take a week off and then come back and do a fireside chat with Dr. Jody Dinnerman. So make sure you go on website website and register for these upcoming webinars. Evan, we are so thankful that you joined us today. And y'all know he'll be back because, well, he's family. So
certainly.
And he's entertaining even when he talks about stuff.
And
right now it's the only way I get to hang out.
But we had to do it. So now you guys know. And we'll do it again maybe next January. We should do one for 2022, okay?
Yeah, absolutely. All right. Well, I hope you guys have an amazing rest of your day and a fabulous week. And I will see y'all next Tuesday. Same time, same place. Bye, y'all.
Bye-bye.